JB Durand. I'm at MD Anderson predominantly. I do practice at Methodist as well. I've been a Methodist since 1996 as a staff member. I'm going to talk to you about syncope. At our institution, 20% of our patients, so 1 in 5 consults, have to do with syncope. We define that as loss of consciousness and postural tone with spontaneous recovery. The mechanisms, there's loss of brainstem perfusion, the reticular activating system for approximately 10 seconds. The incidence is about 3% in ED visit, 1% of hospital admissions, and 33% will present with an injury of some sort. When you look at syncope, it remains unexplained in about 1/3 of cases. When you look at this pie diagram, about 34% are unknown, 24 are neuromediated, 18 are cardiac, 11 orthostatic, and 10% neurologic. Overall, the survival of patients with syncope according to cause. Here is a probability of survival looking at all the different causes. And you see at the very bottom in red that cardiac cause carries the worst prognosis. That's where we come in. History is the key to doing a syncopal evaluation. The mechanism of syncope is unexplained about 40%. You have to define the disease. Did they lose consciousness or did they lose postural tone? And the situation surrounding the event. Was it a car accident? Was it swimming? Was it while they were in their bathroom or exposed to a shocking event? And looking at more history, we look at the symptoms pre-event, whether or not they had palpitations, the onset and offset, the presence of chest pain or shortness of breath, flushing, and then post-symptoms. Did they develop a post-ictal state? Was there confusion, weakness, or numbness, incontinence, or tonic-clonic seizures? The physical exam, checking for orthostatics, blood pressure supine, sitting, and standing, and then auscultation, especially important as a cardiologist if you're looking at a differential of aortic stenosis versus hypertrophic obstructive cardiomyopathy. The EKG, you look for a prior infarct, Brady or tachyarrhythmias, QT interval or QT prolongation, Brugada's syndrome or ARVD, and actually now this should be changed to AVD because we can see left ventricular dysplasia as well. The diagnostic NEAL, unfortunately, is only 2 to 7%. The echocardiogram helps in your evaluation to look at valvular pathology, LV and RV size, the wall thickness if you're looking for Holcomb, and then obstructing mass such as myxoma. Medications that can be involved in this as well is to consider the interactions of drugs such as Viagra and nitrates, the antihypertensive drugs with heart failure agents, especially antiarrhythmics, quinidine, sotalol, dofetilide, and flecainide, and QTC prolonging drugs, psychotropic drugs, hypoglycemic agents, and illicit drug use such as cocaine or barbiturates. Orthostatic hypotension reflects about 1/3 of all cases. It's at least a 20 millimeter systolic drop or 10 millimeter diastolic. If upon standing 500 to 800 mLs of displace to the abdomen or lower extremity, there's a drop in venous return and a lower cardiac output that leads to syncope. Reflex mediated syncope is a response to triggered results with increased vagal tone and withdrawal of sympathetic tone. There's different types based on triggers: micturition, defecation, swallowing. The most common subtypes are neurally mediated syncope and carotid hypersensitivity. The triggers can be anything from sight of blood, prolonged standing, and stressful situations. There is a compensatory response of an increased heart rate and contractility in an underfilled ventricle. There is a paradoxical reflex for mechanical receptors, leading to withdrawal of peripheral stimulation and vasodilation and bradycardia. Neurocardiogenic syncope treatment involves mineralocorticoids, beta blockers such as atenolol, midodrine, serotonin uptake inhibitors, and others such as theophylline, scopolamine. Non-pharmacologic measures, orthostatic training, support hose, or permanent pacing. Carotid sinus hypersensitivity is a stimulation of the carotid baroreceptors from gentle pressure over the carotid bifurcation. The gentle pressure is applied for 5 to 10 seconds. The hypersensitivity exists if there's a sinus pause for 3 seconds or more, or a fall in systolic blood pressure of greater than 50 millimeters. Cardiogenic syncope involves arrhythmias, tachy and Brady, anatomic such as AS, HOCM, ischemic atrial myxoma, or a massive pulmonary embolism. LifeS has really taken life of its own. It's a technology we find actually quite helpful at our institution for patients who are not candidates for defibrillators. What greater way than to put a LifeS on them and send them out the door if they have to be discharged, and then they can come back for close follow-up. The indications are an EF of less than 35%, and a myocardial infarction or non-ischemic cardiomyopathy. They have to be out at least 40 days during the 40-day waiting period. Before and after a CABG or a PTCA covering the 90-day waiting period for an AICD, patients that are listed for a transplant, if they were recently diagnosed with non-ischemic cardiomyopathy, especially if you're waiting the 3 to 9 months that you have to document that they have responded to medical therapy prior to placement of AICD. Terminal diseases with life expectancy of less than 1 year. So who is this individual that's up? So most of you are probably too young to know him. No one knows who this person is? So Hank Gathers. So during the NCAA finals, he dribbled down court, and this was caught on national television. And he had HOCM. He had a cardiac arrest. It took 2.5 hours before he finally got to the hospital. He died on national television. What was interesting about his case was that his cousin, who was 16 years old in Philadelphia, also died on the basketball court. And at that time, a determination was made that, in fact, this was familial in origin. But there's a whole host of other inherited cardiomyopathies that you have to consider in part of your history as part of your evaluation, besides HOCM, long QT, WPW, arrhythmogenic RV, and now should be LV, cardiomyopathy, Brugada, dilated cardiomyopathy, anomalous coronary artery, and myocarditis. ARVD is now predominantly fat deposition in the right ventricle and the left ventricle as well. It's described. This is a cross-section of a HOCM heart, and you can see the amount of thickening in the left ventricle, the interventricular septum, as well as the RV as well. Atrial myxomas are a common thing that we have. We actually have a program with Methodist Hospital where we have a cardiac tumor program. Over 400 cases have been done by one of our surgeons, Dr. Michael Reardon, and we identify this surprisingly quite often. Bradyarrhythmias, he kind of covered a little bit, sick sinus syndrome, AV block, Wenckebach, as well as complete heart block. This is an example of a Mobitz types 2 where you have a drop QRS and a third degree where there's complete AV dissociation. As you can see by the arrows, the atrial and the ventricular rates are completely dissociated. A Holter monitor is what our typical go-to move is. When we see a patient and we are doing our initial evaluation, Holter monitor seems to be the first thing we reach for, but you have to look at the breadth of the amount of information that you're able to garner from a 24-hour evaluation of a Holter. So the 30-day event recorder is nice because it gives you a little bit more detail, especially in those patients who do not have frequent symptoms. Your high likelihood you will miss it if they don't have events very frequently. Therefore, the event day, the 30-day event recorder, are a nice way to interact. And what's nice about it, you can have patient triggered, but this also can be set so that it automatically will detect whatever you want to set the parameters on, and this information can come to you by way of a computer and a service that provides that. The tilt table tests is something we typically don't utilize that terribly much. If we have to use it, if it gets to the point where we have to use it, then I usually will send them to an electrophysiologist to take over at that point. This is done with and without isoproterenol, with and without sublingual nitroglycerin. The sensitivity, however, is why I usually will start to refer those patients to an electrophysiologist. The sensitivity is not that great, and you get to an important decision tree in your algorithm where you have to make a decision. That's where I think the electrophysiologist can be very, very helpful. The Reveal implant is one that we utilize quite a bit. The Reveal implant was the size as an implantable loop recorder that was the size of a cigarette lighter. The most recent model is significantly smaller. It can be done in your office. Literally, it takes about 3 minutes to do. There's a delivery system that you can deliver this percutaneously. It is recommended. They don't even really need antibiotics. You put this in, they're ready to go. It communicates with you wirelessly. I can get information about patients on my cell phone. So it's a very nice technology. The indications for it are patients who experience transient symptoms such as dizziness and palpitations, syncope, chest pain that may suggest cardiac arrhythmia. The utilization of this has been expanded. It now is utilized for management of atrial fibrillation. And I understand, and I've seen a lot of the electrophysiologists will implant this after an ablation. So it's great because we can pick up a lot of additional data after an ablation as well. This is a fairly typical interrogation that we get. The Reveal usually lasts about 3 years. We've been very fortunate. I've never had to keep one in longer than a year. I've had many Holters and event recorders where I didn't detect information. What's nice about the Reveal implant is once you get the information that you need, then your algorithm is they either need a pacemaker if they have a bradyarrhythmia, or if they have a tachyarrhythmia that is simple enough for me to treat, then I will tackle that, and if it's more complicated, I will send that on the EP. One provision I will make, if you are going to implant this in your practice, there's a responsibility that also goes with interpretation. So there's a lot of data that comes to you, and if you're not prepared to act on that data, I would highly recommend you refer those to an electrophysiologist, because there's tremendous amount of data that comes from this, and you have to make a decision about this. So syncope and testing options and diagnostic yield. You see the EKG is 2 to 11%, Holter monitoring is 2%, external loop recorders are 20%, and as you work your way down, you see that there's quite a range. With the Reveal, it's 43 to 88%. The RAST study was a randomized assessment of syncope trial, and it looked at the yield and cost effectiveness of looking at internal loop recorder versus conventional testing. And what it found was the diagnostic yield was 43% for the implantable loop recorder, but half that much for conventional, and the costs diagnosis with an implantable loop recorder was about 26% less than conventional testing. So there's an education opportunity. There's lack of diagnosis on ECG, Holter, or external loop recorder. This does not cure the patient or relieve the physician of the responsibility to diagnose the etiology of the palpitations near syncope or syncope. There is scientific statement on the evaluation of syncope, and I've put in the orange box that these frequent episodes correlate with symptoms. The implantable loop recorder help, especially when you have infrequent symptoms. The Rose study looked at risk stratification of patients with syncope. The sensitivity was about 82%. The specificity was 65%, looking at number of parameters for when you should admit, including a BNP level or a bradycardia of a heart rate of less than 50. So syncope, the history and physical exam are the most important. Evaluate for drug-drug interaction. A negative test does not permit giving up on a patient. Use tools that give you the most amount of information to help you obtain the diagnosis. When everything is negative, keep looking. You have to continue to look very, very carefully for this. And I'll close with offering you that we have a financial boot camp that we do, that we will have our 6th session on January 8th of 2016. We work with Dr. Lynn with the Methodist Fellows. What's nice about this is you come in, you can choose a Saturday or Sunday. It's usually about 6 hours. And we go through everything, things that you don't learn during your fellowship. That is, things as contract negotiations, how to invest for in retirement, how do you invest in a college fund, how do markets work. So it's a nice opportunity to learn about financial boot camp. So thank you, and I guess we'll take questions later.